This presentation was recorded at the 2015 ANZICS ACCCN Annual Scientific Meeting.
Right, well, welcome to the second session this morning. Just before we start, I would like to take the opportunity to acknowledge and thank Fiona Miles and Ginny for all their work in organising the paediatric aspects of the program. It's obviously been fantastic so far. Unfortunately, I couldn't be here yesterday, but looking forward to the rest of it. But it's been a huge amount of work trying to get these things done. And I do remember with Fiona that she was trying to get everything tied down last year before the Melbourne conference was already sorted, so that she was organised well in advance. This session is entitled Death and Dying in PICU. It's obviously a very important topic. Most of the children with acute illnesses that die in hospital these days all die in paediatric ICU, and many of those with chronic conditions do as well. So it's a really important topic, and I'm looking forward to the presentations. The first speaker is Associate Professor Stephen Jacobe from Sydney, from Children's Hospital at Westmead, where he's a senior staff intensivist and is also our representative on the World Federation of Paediatric Intensive Care and Paediatric Intensive and Critical Care. But particularly germane to this session, he was also the paediatric representative on the ANZICS End of Life Working Group. Thank you, Stephen.
Thanks very much for the kind introduction and the invitation to talk to you today. I want to talk about death. As John said, it's a fairly important subject, and one that will involve us all at some stage. I can assure you of that. I want to talk about ambiguity surrounding death too. This struck me last year. I saw it in the Herald that this man actually survived death, which is something we'd all like to do sometime. But I can assure him that he won't survive forever. This is the lifetime mortality for Homo sapiens, and as you can see, it hasn't changed much over many, many years. It in fact affects about 150,000 people each day die around the world. I want to talk to you about a case just as an introduction. This involved a young girl I call Sophie. She was 2. She had an out-of-hospital cardiac arrest. She was found at home by her grandmother after possibly choking on a grape. The last time she was seen, she was eating grapes. And there was no bystander CPR. She was found at around 7:05 in the evening. The ambulance arrived around 8 minutes later, and she was asystolic. They gave a couple of doses of adrenaline, 20 minutes of CPR before she arrived in the emergency department. There she had further CPR, further 3 doses of adrenaline, and she had pulseless electrical activity. pH was 6.7. There was no pulse palpable. She appeared lifeless, and she was declared dead. Around 17 minutes later, some respiratory effort was noted. She appeared to have resuscitated. She was ventilated, transferred to PICU. Overnight, she developed signs consistent with brain death, however. I'd performed a single set of brain stem reflex tests, and she had no response at all. A brain perfusion study was done. That was also negative. Her parents declined the opportunity to explore organ donation, and she was extubated at 20:42. I examined her around 50 minutes later, and there was no pulse, no heart sounds. Her parents asked me that evening, when did their child die? They wondered if she died at home. They wondered if she died in the emergency department. Or did she die when a perfusion study was negative? Or did she in fact die when she was extubated, or when I examined her later? Death shouldn't be so hard to define, but it sometimes is. Pliny the Elder said in 77 AD that such is the condition of humanity, and so uncertain is men's judgment that they cannot determine even death itself. And in fact, in those times, diagnosing death was difficult. There's a few accounts of Roman noblemen sort of waking up on their funeral pyre, just sort of, help, save me. Unfortunately, they weren't able to be saved, but so they did die in the end. But defining death is very important. It's not just a trivial exercise in coining the meaning of the term, but it's an attempt to reach an understanding of the philosophical nature of man and that which is essentially significant to man, which is lost at the time of death. What is it that we lose when we die? Because obviously whatever it is also signifies life. Death is also important for many rituals. Once you die, You can start grieving, or the family can. The religious rites can occur. From a medical point of view, it's important because treatment can then stop. Organ donation can occur in some circumstances. And there are legal things that can occur, but not until someone is legally dead. Can you be a bit dead? Some argue that it's a process that you go through. Dying is a process, and we all acknowledge that, but you can't be a bit dead. It's like being a bit pregnant. You're either dead or you're not. This is a picture of Schrodinger's cat, who was hypothesized that you could be dead and alive at the same time, but I think most people felt that was a nonsense. You're either alive or dead. But determining what signifies death, because of it's a process, usually depends on societal consent, and so you have to get consensus amongst society about death. Ancient medical dogma, you can imagine it was pretty difficult back then to decide if someone's alive or dead. There were the 4 humours which came from food. That's why a balanced diet was so important. They were processed in the liver, and blood was felt to go from the veins to all around the body. Air came in and out through the pulmonary vein into the left side of the heart where it mixed up with blood. The air, or pneuma, was also part of a spirit, and it was felt that was important. So both the heart and lungs, or breathing and circulation, were known to be important, but it wasn't certain how they related to life. In the Dark Ages, leading up to the Dark Ages, life was fairly fatalistic. Everyone died. You just knew you were going to die. You may as well prepare for it. And there was life wasn't that good, perhaps. So there was a lot of focus on the afterlife. So a lot of life was preparing for death and preparing for the afterlife. Hopefully, if you were good, when the Last Judgment came, you'd go to heaven for eternity. Otherwise, you wouldn't be so well off. In medieval times, I don't know if you can see that, I'm afraid the light's on, but that's the Bring Out Your Dead thing from Monty Python. But in medieval times, the mortality rate for infants, about 3 out of 10 died before 1 year of age. There was the 100-Year War, the famine. Death was part of everyday life. Everyone knew people who died, and there were dead bodies around. The Black Death, in 3 years, wiped out, it's estimated, up to 50% of Europe's population. Some estimates put it at 200 million people in 3 years. It's almost like modern-day Ebola, like if Ebola had been let loose in Europe. The case fatality rate for the bubonic plague was up to 80%, so there's some more similarities perhaps. It wasn't until the 17th century that Europe's population reached pre-plague levels. So death was certainly a part of life. And also, once you had bodies around who've died of pestilence, you don't want them hanging around long. So getting them buried quite quickly was important. The Ars Moriendi is some ancient text which once again is a series of woodcuts to instruct people on how to have a good death and prepare for death. And during death, to resist the temptations. There were 5 temptations that you had to resist. And hopefully then you'd make it to heaven in the afterlife. Death affected everyone. No one was spared, no matter what your social status. Then we come to the Renaissance and the scientific revolution. Science relied more on experimentation to prove things and disprove things. The body was seen as a beautiful machine that could be studied, and if it was a machine, maybe if the machine stopped, you could start it again. Nature could perhaps be mastered, and if there was this potential to improve your life in the here and now, and the afterlife appeared to become more or less important. Also during the Enlightenment, resuscitation started to become used. There was Lazarus, of course, who was called from the grave after 3 days, and I'm sure he did stinketh by then, but he was probably one of the first cases of resurrection or resuscitation. But in the 1700s, there was smelling salts to wake people from syncope, artificial respiration, and in fact mouth-to-mouth resuscitation was first described in 1745. There was electric shocks used to resuscitate dogs and humans. And there was a Dutch Society for the Recovery of Drowned Person formed in 1767, and the Humane Society in the UK followed soon thereafter. Obviously, there are a lot of canals in Holland, and you can download this on Google Books. This is the short account of a society of for the recovery of drowned persons. And you can see that it has some accounts. This is translated into modern English, but I was just reading this and a bit gobsmacked, I guess, that this lady was pulled out of the deep canal. She'd been there for quite a while, and luckily this skipper from Gouda came along. He'd read about this resuscitation technique, so he got his pipe and put it up her bottom, and, you know, it wasn't just one bowl of tobacco, two bowls until she recovered, and then she was able to be carried home. So I don't know what the onlookers were thinking at the time. We're lucky we just have to be called upon to do mouth-to-mouth these days, but I'm sure she got to keep the pipe as a memento. Galvanism, Luigi Galvani was an Italian who experimented with electric shock and could make muscles twitch. His nephew, Aldini, famously toured England in 1802, and in 1803 he was given the freshly hung corpse of George Foster, a murderer. And at the Royal College of Surgeons, he got his batteries and his electrodes and was able to make the corpse twitch. One of the eyes opened, his jaw quivered, and in fact he sat up at one stage. So the surgeons felt this was fantastic. Some people felt that he was going to come to life, this freshly hung corpse. So it sort of blurred the boundaries of what exactly is life if you can make a corpse apparently come to life. It was perhaps no mere coincidence that 15 years later Mary Shelley also used electricity to bring Frankenstein's monster to life. And around 150 years later, the first case report of a 14-year-old boy who had VF arrest in theatre, also brought to life with electricity. There were many death counterfeits that were worried about, things like hibernation, suspended animation, catalepsy, hysteria, opiate intoxication. In the mid-1800s, anesthesia was around, so you could put someone deeply asleep, so they appeared to be in a deep coma. So people weren't sure if these death counterfeits could be mistaken for death. And there was a big fear of premature burial in the 1800s. People were worried that they were going to be buried and be by themselves alone in the narrow embrace, or the rigid embrace of the narrow house, as Edgar Allan Poe stated. As I said, this was countered by a few devices to prevent premature burial. Some of these coffins, up here you can see the handles on the inside, so you can let yourself out. This is a safety coffin, so if there's movement there and the ball moves, the flag goes up and a bell goes off for 30 minutes. This was the Edgar Allan Poe's premature burial novel. These are waiting mausoleums where the bodies would be laid out for several days and surrounded by fresh flowers to hide the smell. But putrefactive decomposition was felt one of the sure signs of death. There were other tests for sensibility, things like mustard up the nose, smelling salts, trumpet, yelling, breath detection. You could inject subcutaneous ammonia and see if there's a reaction. If there isn't, they're probably dead. Some were intercostal incisions and direct palpation of the heart, or you could put flags in the needles with flags, inject them into the heart, and look for little movement of the flag. A lot of these tests, obviously, if they weren't dead when you started, they would be when you finished. But people were very concerned about being premature or buried prematurely and waking up in a coffin. So some actually asked or paid a surgeon to take their heart out, for instance, or cut their carotids so that they wouldn't wake up in a coffin. These are some of the absolute signs of and proofs of death, which are once again lots of tests, but notably at the bottom is putrefactive decomposition, which by the time you get to that stage, I think you're safe to bury them. There was a chap called William Tebb who was a businessman and social campaigner. He was also an anti-vaccinationist, and he was fearful of the power that doctors were getting around the 1800s. And he published a couple of editions of this book on premature burial and how it might be prevented, and in fact lobbied the government for introduction of laws that would govern doctors and certainly around the certification of death. You should remember that until the 1800s, death wasn't really a medical thing, it was a religious event. Doctors only started diagnosing death in the 1800s specifically. And in fact, Hippocrates said that if a doctor diagnoses someone that death is approaching, they should then back away. And it would be up to lay people to diagnose death. But in the 1800s, doctors were starting to diagnose it. I think most would agree that when the soul leaves the body is probably the moment of death. So this Dr. McDougall felt that if you could weigh that, you could perhaps weigh the soul. See, this thing as it leaves. In fact, got 6 patients who were suffering from TB. He didn't want them to struggle too much. So they had to be wasted and cahectic. And they were put on weighing scales. And he thought, watched them as they died. And as they died, the first body lost 3/4 of an ounce, which is where this 21 grams comes from. The other body, another person lost 3/8 of an ounce. Another 2 dropped, the scales dropped, then dropped again, so they thought maybe they died twice. One sort of took a long time to drop, and they thought he was a really stubborn, cantankerous man when he was alive, so maybe that reflected his soul. So it wasn't a good experiment. I don't know that it's been reproduced since, but death in the past was always neurological death, but it was often preceded by circulatory death. Like if you stopped breathing, your heart stopped, you became hypotensive, your brain eventually stopped. So it was just a natural progression. There was final common pathway, was neurological death. Resuscitation, however, prevented that. It decoupled those two events. So that resuscitation now, if your heart stopped, you could be resuscitated. You could be kept alive. So it decoupled this nexus between circulatory death and brain death. There was a bizarre experiment. This is Alexis Carroll, who did a lot on perfusion and was sort of a pioneer around organ transplantation. He was awarded the Nobel Prize for medical physiology in 1912. In fact, he was the first American to get a Nobel Prize, although he was French originally. But this is a dog's head that's been perfused via this, and if you in fact see the video on YouTube, which is quite macabre, but the dog's head still responds to a feather up the nose and to noise. But although there's responses there from this decapitated head, I think most would agree that the head is dead. But it was a bit puzzling about what signifies life and death. Is it just responses? An EEG was developed in 1927, so people could actually look at the brain now. They could study the activity of the brain. The eye and lung, as you know, was developed in the 1920s, so patients could be ventilated. There was a group of patients in the 1950s that French neurologists said they were beyond coma. They had no responses at all. When they eventually died, and they all did, examination of the brain showed that they had necrosis of the brain. So coma dépassé was sort of, I think, the first description of brain death. There was a papal declaration in 1957 to the International Society of Anaesthetists. They posed the questions about these patients who could be resuscitated. And the Pope said that you didn't have to undertake extraordinary means to keep these patients alive. First lung transplant was 1963, and sure you'll all be aware of the first heart transplant in 1967, performed by Christian Barnard. It was on using the donor was a white woman around 29 years of age who was involved in a motor vehicle accident. She was said to have a lethal brain injury. She wasn't brain dead, but it was said to be lethal. So it was a DCD donation. They took her to theatre, draped her. The state forensic pathologist was invited in. They withdrew ventilation. The heart stopped. She was declared dead by the pathologist. And then her heart was taken out by Christian Barnard. It was quite a famous case. A lot of the work was done by Norman Shumway in the States, but America was grappling with the ethics of donation at that time, and Christian Barnard sort of got in. There were no laws in South Africa at that stage surrounding this issue. He was very careful to make sure it was a white donor, of course, and it really made his career, so he became famous after that around the world, and it surprises all of you, I'm sure, that there's a cardiac surgeon with a healthy ego. But he toured the world on the back of that. In the following year, there were over 102 heart transplants, but they didn't go very well. They had a one-year mortality or survival rate of 19%, so most patients died in the first year, and only 10% were alive after 2 years. did lead the group at Harvard to get together, and they met to discuss brain death, and they said that medical opinion is ready to adopt a new criteria for pronouncing death. So this is quite a big step to pronounce death by new criteria. These were the Harvard criteria, which are not that different to what we use today. Australia, most states in Australia have a statutory definition of death. There isn't one in New Zealand nor in Western Australia, but it's irreversible cessation of the brain or the circulation of blood. ANZICS, as you know, have some guidelines around how to diagnose death, particularly after DCD, and generally the recommendations are you should wait between 5 and 10 minutes around the world for DCD. New South Wales has just released guidelines for paramedics and registered nurses who can verify death. They're not allowed to certify death, but they can verify death. DCD and the dead donor rule. The dead donor rule states that you can't take organs from living people. They could only be taken from dead patients, and obviously that the living patients can't be killed for organ retrieval. That's not allowed, which sounds reasonable. Some of you will be aware of this Monty Python sketch too, where Mr. Brown, these two people come in and say, "We want your liver," and he says, "I'm still using it." He says, "What's this then?" It's your liver donor card. He says, "No, I'm still using it. It says in the event of death." And they say, "Oh, no one survived after we take their liver out." So death, after DCD, death has to be pronounced very quickly because you have to minimise warm ischemic time. So the diagnosis of death in DCD donation becomes very important, obviously. So as I said, usually people recommend between 2 and 10 minutes. Most of you will be aware of this paper, though, that involved heart transplantation after paediatric circulatory death. And they initially used a 3-minute period, but in fact their ethics committee recommended a period of observation of 1.25 minutes, or 75 seconds. Their ethics committee said that was enough to declare someone dead. So 75 seconds, you can take your heart out. Put it in someone else and it'll work, but they were dead at the time. There's some semantic distinctions drawn about what's permanent, what's irreversible. Ones won't be resuscitated, the others can't be resuscitated. Some things about circulatory versus cardiac, because obviously if the heart starts again in another body, it could be argued it wasn't irreversibly stopped. Auto-resuscitation can occur. There was a famous case, it may be apocryphal, but in 1857 a pathologist was in New York doing a post-mortem, and apparently the corpse woke up and grabbed him by the throat, and the pathologist died of apoplexy, but the corpse was resuscitated and lived, so apparently that happened. But it can happen. There's, in the literature, not a lot of cases. There's about 32 cases, all adults. There are a couple of case reports of children who have been auto-resuscitated, but not many at all. When they've looked at these, they're mainly just bad case reports that aren't very well described. But when you do look at the better ones, where they've got continuous ECG monitoring, there's been no case greater than 7 minutes, and all of them occurred after failed CPR. None after planned withdrawal of life-sustaining treatment, so it probably doesn't concern us too much about those cases with DCD where you withdraw life-sustaining treatment in a planned fashion. This just shows 7 minutes was the longest case of well-documented auto-resuscitation. Can we diagnose acirculation by pulselessness? A couple of studies from Tibbles shows that our accuracy of feeling a pulse isn't that good. So in cases where there's PEA, a child might have pulseless electrical activity, confirmation of acirculation is useful. These studies found that the brachial palpation of the brachial pulse was a bit better than femoral, and if you do it greater than 30 seconds, your accuracy was better too. So in summary, there's a narrow yet profound difference between dying and dead, and we shouldn't confuse the two. Auto-resuscitation is very rare, but it has been described following CPR. It's not described following planned withdrawal of life-sustaining treatment. The time of ceasing non-beneficial CPR is not the time of death. no matter what they say on ER, when they say, oh, you know, I'm calling it time of death 1532. That's not the time of death. You must go back and examine the patient. In the presence of ongoing cardiac electrical activity, such as pulses electrical activity, confirmation of ace circulation by echo or an intra-arterial line is certainly helpful if you've got it, if you can do it. It's helpful. And there's no need for haste. At least a 2-minute observation period should be undertaken. If someone would say how to diagnose death, you'd say carefully, slowly, thoughtfully. Just take your time. Generally, there's no rush. Theodore Dalrymple was an editor of British Medical Journal. He said as an exhausted houseman, he was rung in the middle of the night by a nurse on the ward who said, "Oh, doctor, I think Mr. Jones has died." He said, "Well, if you're right, nurse, he'll be dead in the morning," and he hung up and went back to sleep. Finally, a person is dead when a physician says so. So, Sophie's parents requested that she die when she was extubated, 2042. That was the time she was born. Thank you.